Okay, I think we're going to get started. Welcome to the final grand rounds of the 2020 year. Looking forward to a 2021 season that's hopefully more normal. Today we're going to have MJ, or Miranda Rogers, give a presentation to us on targeted muscle reinnervation from neuroma management to myoelectric prostheses. And looking forward to this. It's a hot topic within the field of upper extremity, but also lower extremity surgery. And interested to hear what you have to say, MJ.
Awesome. Thank you so much, Dr. Tischer. Can everyone hear me okay?
Yes.
Okay, perfect. So my name is Miranda. I'm one of the PGY4s. I'm here to give my grand rounds presentation as we work our way through the 4th year resident lecture series. This will eventually end with Michelle because we've saved the best for last this year. Today I'll be discussing targeted muscle reinnervation and its current role in orthopedics as both an avenue for neuroma management and in optimizing prosthetic use. So we'll start with an introduction to TMR and why it's relevant to orthopedics in general, and specifically for providers caring for patients after amputation. We'll touch on indications and utilization of this procedure, and then take a hard look at the current research on the topic. Finally, we'll end with the future roles for this intervention and how I think we can improve our use of it moving forward. But first, I'd like to run a quick poll of the group to get an initial impression of what you guys believe TMR to be best used for. I'll give folks about 20 more seconds just to pick their answers and give their thoughts. All right, perfect. I'm going to end the poll there, guys. Okay, so we're starting with a reasonable kind of spread. 10% of people are not sure what it's for. Some folks think it's good for diabetic limbs. Majority think it's good for neuromas and then restoring nerve function in someone with a nerve injury. And then some sassy people think it's to charge a patient for an expensive procedure. Now I want you to picture a typical Thursday at the U. You're perusing the board, wondering if the scheduled surgeries are truly urgent enough to bump your elective case during a pandemic. Your eyes find something truly unique. You notice that Dr. Kasmers is scheduled for a targeted muscle reinnervation, and you can't help wonder what that actually means. TMR was developed by Dr. Dumanian and Dr. Kaiken at Northwestern Memorial Hospital in the early 2000s and was focused on improving the control of myoelectric prosthesis use for patients with upper extremity amputations. It was initially developed specifically for shoulder disarticulations and transhumeral amputations, and Dr. Dumanian performed the first TMR procedure in 2002 on a patient with a shoulder disarticulation. A serendipitous outcome of this pioneering surgery was the additional noted benefit of reduced neuroma pain in amputees. TMR involves transfer of amputated nerve endings that formerly innervated distal muscles to proximal motor nerve branches that innervate muscles with redundant function. This is essentially switching the innervation of a residual proximal muscle to be under the control of one of the lost major nerves from the amputation. A reasonable example is in the setting of an above elbow amputation. In this situation, there are two heads of the biceps present and median nerve function is lost, i.e. grasp. You can switch the innervation of one of the heads of the biceps from the musculocutaneous nerve to the median nerve, which allows one head of the biceps to signal biceps flexion and the other to signal grasp in a highly intuitive manner. The newly reinnervated muscle serves as a biological amplifier, allowing detection of a signal from a previously lost nerve. The end result is amplification of motor signals from nerves that no longer serve a downstream function, enabling them to be detected by surface electrodes, therefore controlling myoelectric prostheses. The additional motor signals are interpreted by the prosthesis and converted into the corresponding motions. The end result of TMR is a significant increase in the number of motor signals available for those with amputations, which in turn allows a greater amount of functional control of myoelectric prostheses at each amputation level. TMR consists of nerve transfer from the transected peripheral nerve to a nearby motor nerve branch. The transected peripheral nerve can either be mixed motor and sensory or pure sensory. The regenerating axons from the proximal nerve stump grow through the existing endoneurial tubes to reinnervate the motor end plates of the freshly denervated target muscle. TMR has been shown to result in physiologic synaptic input. There are 3 core steps involved in performing TMR, which you can see listed here. They involve preparing the injured nerve and identifying the motor branch you want to target your transfer to and coapting the nerves together. Although general TMR techniques have been described, the pattern of nerve transfer is non-prescriptive and depends on the amputation level. It also depends on the length and function of the local peripheral donor nerves, as well as the presence and function of remaining muscle targets. A reasonable example is in the setting of transhumeral amputation. At this level, only the biceps and triceps are able to create meaningful signals for a myoelectric prosthesis. You can separate the heads of the biceps and triceps, recruit the brachialis, and switch innervate some of the muscles with terminal radial, median, and ulnar nerves to increase the number of signals available for use with modern myoelectric prostheses. For example, the medial head of the biceps can be denervated by cutting its musculocutaneous nerve motor branches and then reinnervated by coapting the median nerve to those motor branches, allowing the medial head of the biceps to contract intuitively when grasp is desired. The preserved lateral biceps head, still innervated by the musculocutaneous nerve, contracts normally when elbow flexion is desired. Similarly, one triceps head can be switch innervated with the distal radial nerve to control digital extension of myoelectric prosthesis, while remaining radial motor nerve branches are preserved for elbow flexion, or elbow extension, excuse me. With the caveat that TMR is a relatively new presence on the scene, the documented indications for TMR include the treatment of chronic, recurrent, or unreconstructible neuromas, the management of nerves and acute amputations, and for the treatment of chronic amputee pain. While focusing on TMR for future prosthetic use, the contraindications for TMR include an upstream ipsilateral brachial plexus palsy, major medical comorbidities that make a complex surgery unsafe for the patient, and anticipated prosthetic noncompliance in the absence of painful neuromas. For successful myoelectric control after TMR, each reinnervated muscle must generate EMG signals only in response to the transferred nerve. Many muscles are innervated by multiple motor branches, and all native motor innervation of the target muscle must be cut to avoid a combination of natively innervated and reinnervated muscle fibers. Successful TMR also requires robust reinnervation of target muscles. It has been previously shown that reinnervated muscle typically does not regain prior mass or functional capacity. Animal studies have shown that reinnervation with an excess of donor nerve fibers, i.e. hyper-reinnervation, results in improved muscle recovery. This occurs in TMR when large brachial plexus nerves containing many thousands of motor neurons are transferred to small distal motor nerves, increasing the odds of any individual muscle fiber being reinnervated. This also allows you to overcome the age-related reduction in peripheral nerve regeneration. And TMR has been reported to have been successfully performed in adults up to 68 years of age. Finally, it's important to avoid crosstalk, particularly if the end goal is to facilitate myoelectric prosthesis use. The prosthetic requires EMG signals that are free of contamination by EMG signals from adjacent muscles. To prevent nerve fibers from reinnervating adjacent muscle segments, you can surgically separate them by generating a physical barrier of scar tissue or an adipofascial flap insertion. You can also reduce the fat layer that will attenuate EMG signal and move nerves away from bone that will interfere with the signal delivery to prosthesis electrodes. That was a lot of information, so let's review why I found this topic important enough to force upon you via grand rounds. In 2005, an estimated 1.7 million people in the US were living with a major extremity amputation, a number projected to double by the year 2050. Of these, more than 500,000 sustained an amputation of the upper extremity, with more than 40,000 limbs lost at or above the level of the hand. Upper extremity amputation is most commonly the end result of high energy trauma in the young, otherwise healthy patient population. Between 2001 and 2010, more than 1,000 military personnel suffered traumatic amputations, which ultimately prompted the Department of Defense to identify the treatment of post-amputation neuroma pain as a primary focus area for funded scientific investigation. Of the 1.7 million people living with major limb amputations, approximately 25% will develop chronic localized pain secondary to symptomatic neuromas. The proportion of patients with residual limb neuroma pain after traumatic amputation may be even higher. This complication has been reported in up to as many as 71% of these patients. In contrast to the lower extremities, where a prosthesis functions as a load-bearing platform for ambulation, the dexterity and degrees of freedom in the upper extremity are not as well replicated with existing prostheses. In contrast, the primary functions of the upper extremities include not only gross and fine motor activities, but also more complex combination of activities such as self-care, interaction with the environment and others, and self-expression. Thus, it's not surprising that people with upper limb amputation are generally less satisfied with the restoration of function provided by their prostheses relative to those with lower limb amputation. It is relevant to quickly touch base on the surgical techniques surrounding TMR, as it provides clarity into the procedure and the depths in which it can be used. TMR generally starts by identifying and mobilizing the donor nerve you want to transfer. The nerve is dissected and is generally performed under magnification with the appropriate tools for handling and managing nerves. End neuromas are removed with the goal of maximizing the length available to provide freedom in your transfer. The fascicles should be trimmed until you can see them sprout from the end. You then turn your attention to identifying the target muscle with its associated native motor nerves. A handheld nerve stimulator is required in order to avoid tiring out the motor nerve, which would render it unstimulatable, in order to locate intramuscular motor points. The target muscle varies depending on where you are working and if you are in the upper or lower extremity. We'll touch more on that later. Finally, you connect the donor nerve to the target motor nerve via coaptation. Ideally, this is via a tension-free end-to-end repair, facilitating reinnervation of the specific motor endpoint. The coaptation site should be as near to the muscle belly as possible to decrease innervation times and facilitate placement of a supportive epimysial suture. Some resources discuss augmenting the coaptation with epineurium to epimysial repair, particularly if there is a mismatch in the caliber between the donor and the recipient nerves. So with this background in mind, we'll narrow in on the indications and uses for TMR. Let's start with a discussion about neuromas, which are the end result of an injury to a nerve, whether that be traumatic or iatrogenic, such as in the setting of amputation. Axonal injury produces a reparative response. The distal aspect of the damaged axon is generally resorbed via Wallerian degeneration. The proximal aspect has the potential for regeneration and eventually sprouts. If it encounters an empty endoneurial tube in its proximity, it will grow within it at a rate of approximately 1 to 2 millimeters per day. If there is instead displacement between the nerve endings, the sprouting axons are unable to reach the distal endoneurial tube and instead will proliferate at the site of the injury and ultimately form a neuroma. Unfortunately, painful neuromas develop as a result of disorganized fibroblast and Schwann cell proliferation, and they significantly impact patient function. At the time of primary amputation, attempts are made to prevent future neuroma formation. Major peripheral nerves are often managed at the time of primary amputation by traction neurectomy. Additional options include the burial of the nerve ending in muscle or bone, in an attempt to prevent recurrence, as well as various types of grafts around the transected nerve. Ultimately, management of neuromas is important, given that neuromas occur in up to 60% of patients with nerve injury and 25% of major limb amputees. Neuromas impede postoperative rehabilitation and long-term prosthetic use. Additionally, almost 50% of patients have recurrent or persistent neuroma-type pain after traction neurectomy. Simple neuroma excision was shown to have a recurrence in 47% of patients in a study of 56 people followed for 240 months by Gus et al. Male gender was a statistically significant predictor of recurrent neuroma after simple excision. Once a neuroma is present, there are multiple techniques for managing it, including a simple neuroma excision, one of over 100 different treatments that have been described in the literature, including nerve capping, centro-to-central coaptation, and allografting. More recently, TMR has been suggested as an avenue through which to encourage organized nerve healing and either prevent or manage neuromas. As I mentioned previously, neuroma management was a serendipitous discovery as TMR was being used for myoelectric prostheses. There has been a number of studies dedicated to assessing the use of TMR for neuroma management and prevention. Pett et al. Retrospectively reviewed 2 groups of patients, 12 who underwent TMR for neuroma prevention in the setting of acute traumatic amputation, and 23 patients with an established neuroma who underwent neuroma excision with secondary TMR. At their last follow-up, 92% of patients were free of neuroma pain after acute TMR, and 87% were free of it after secondary TMR. However, their assessment of pain was not perfect, as it was based on pain introduced with palpation of the area, and the patients had other reasons for pain, including heterotopic ossification that was removed at the time of surgery. They also did not have imaging confirming that the neuroma had not recurred, and they suggested that additional research should include patient-reported outcome measures and imaging modalities such as MRI or ultrasound to confirm the lack of neuroma. In a retrospective study of 26 patients treated with TMR for improved myoelectric control from 2002 to 2012 at Northwestern, Souza et al. Identified 15 patients that were experiencing post-amputation neuroma before TMR. 14 out of 15 patients experienced complete resolution of the pain after TMR. The other patients that did not have neuroma pain before the procedure did not go on to develop it after the procedure. The mean duration between amputation and TMR surgery was 16 months for these patients. Limitations included the retrospective nature, as well as the fact that validated pain scores were not consistently used. The study was focused on patients indicated for myoelectric prostheses, and the improvement in neuroma pain was an unanticipated benefit. The study ultimately prompted an RCT of TMR versus standard neuroma excision in order to assess the efficacy of TMR for the treatment of post-amputation neuroma pain. This prospective randomized controlled trial was actually started in 2014 and concluded a couple years ago in 2018 with the resultant publication by Dumanian et al. In the Annals of Surgery last year. The study focused on 28 patients who had never received prior treatment for neuromas, and when they were randomly allocated to undergo TMR versus standard neuroma treatment, which is what they defined as excision and bearing in muscle. It took them 3 years of screening 85 patients to find the 28 people included in the study. They captured pain data, very different patient-reported outcome scales. The numerical rating scale, or NRS, was the primary outcome. And then they also used 3 PROMIS assessments: pain behavior, short form 7A, pain intensity, short form 3A, and pain interference, short form 8A. Patients were asked to differentiate between phantom pain and residual pain using an avatar showing this. And then patients also underwent MRIs both pre-op and 1 year after their surgery, with blinded radiologists reading the imaging. Functional assessments were performed using the Neuro Quality of Life Scale in lower extremity amputees and the Orthotics Prosthetics Users Survey upper extremity form for upper extremity amputees. The RCT provided evidence that TMR decreases phantom limb pain in major limb amputees, with an average increase in NRS of 3.2 in the TMR arm, compared with an average increase of 0.2 in the standard treatment arm at the 1 year endpoint. Changes in NRS of 2 points have been shown to be clinically relevant, and it correlates with the need to take pain medications. Residual limb pain showed a trend towards improvement in the TMR group, but did not reach statistical significance. Their secondary outcomes looked at the percent of the group with phantom pain and residual limb pain. 72% of patients who underwent TMR had no or mild phantom limb pain at 1.5 years out versus 40% in the standard treatment group. Also, 67% of patients who underwent TMR were pain-free or suffered only mild residual limb pain versus 27% in the standard treatment group. Functional outcomes did not show a clear improvement with TMR, but there was a trend toward improvement with when crossover patients were included. The significant limitation seen in the study was a low number of patients, as it had originally planned to recruit 200 and instead stopped recruitment at 28. The authors stated that it was difficult to find surgeons that could perform this procedure and complete the IRB in time, as well as the fact that many patients had undergone prior procedures for the neuroma by the time they met them. Additionally, they noted that patients had to self-report pain, and there was some inherent difficulty in helping them differentiate phantom pain from residual limb pain. The next important discussion includes the difference between acute versus secondary TMR for neuroma prevention. Pett et al. Introduced this topic in 2014 when they identified that 92% of patients undergoing acute TMR did not experience neuroma pain postoperatively versus the 87% that had resolved neuroma pain after secondary TMR. This study was focused on myoelectric prostheses, however, and not on neuroma prevention. Valerio et al. Investigated this topic in 2019 with a study that compared 51 patients undergoing major limb amputation with immediate TMR versus 438 similar amputees who did not undergo TMR. Primary outcomes included numerical rating scale and PROMIS pain intensity, behavior, and interference scales. Patients who underwent TMR had less phantom limb pain and residual limb pain compared to untreated amputee controls. TMR was associated with over 3 times higher odds of decreasing both phantom and residual limb pain severity compared to general amputee patients. At this point, TMR is being used throughout the body in an effort to prevent and manage neuromas. In my humble literature review, there were numerous upper and lower extremity case reports ranging from the fingers down to the toes that offer examples of how TMR is being used in practice to benefit patients with a wide variety of neuromas. Now let us focus on the use of TMR in the lower extremities. The primary rationale for TMR in the setting of above-knee amputation is to prevent phantom pain and neuroma formation. In the setting of above-knee amputation, the nerves that are addressed include the perineal and tibial components of the sciatic nerve, the posterior femoral cutaneous nerve, and the saphenous nerve. You can see the primary targeted muscles for these nerves listed in the associated table. The targets differ depending on where you are in the body. The perineal component of the sciatic nerve is usually targeted to the biceps femoris muscle, while the tibial component is targeted to the semitendinosus or the semimembranosus. The posterior femoral cutaneous nerve is connected to the biceps femoris via a distal motor branch, and the saphenous to the vastus medialis. For below-knee amputations, the nerves addressed include the deep perineal, superficial perineal, tibial, sural, and saphenous nerves. Cases in which the TMR is performed concurrently with amputation are managed differently from cases in which delayed TMR is performed in order to treat chronic neuroma pain. In acute TMR, the deep posterior compartment of the leg has a wealth of motor nerves. At the time of tibial osteotomy, the posterior flap should be dissected cleanly off the bone with tibial nerve and vascular bundle. The tibial nerve is then transferred to any large motor nerve noted to emanate off of its substance. Deep perineal nerve is transferred to the tibialis anterior, and the superficial perineal nerve is transferred to the peroneus longus. These muscles are ideal for TMR, as they have a large number of motor points, with many clustered proximally in the middle third of the leg. With this approach for acute TMR, the sural nerves are the most difficult to handle. If found emerging from the end of the posterior flap, they are dissected proximally and then either tunneled through the posterior flap musculature for coaptation to additional motor points, or wrapped with a free muscle graft and treated as a regenerative peripheral nerve interface, or RPNI. We'll talk more about those later. When performing TMR in a staged or delayed manner for below-knee amputations, it is performed with the patient in a prone position with a straight midline incision just lateral to the midline in order to facilitate accessing the perineal nerve. The perineal component of the sural nerve can often be quite large and should not be confused for the common perineal nerve. The medial gastroc is often left alone for the bulk of the lower limb and knee flexion, but it too can be a muscle target if needed. On occasion, a two-incision approach can be performed utilizing anterior, lateral, and midline posterior approaches. These tables reveal the muscle targets for nerve transfers for both single incision and two-incision approaches. The final scenario includes the management of a neuroma in the setting of an intact limb. This is relatively common. The neuroma is first isolated in several manners. First, by asking the patient to point of the area of the worst pain, by eliciting a positive Tinel on examination, or getting transient resolution of the pain with a diagnostic injection of local anesthetic. Incisions are then made directly over the neuroma and can be extended in order to provide access to motor points in the compartment of interest for nerve transfer. The deep perineal nerve is transferred to the extensor digitorum longus, avoiding the possibility of weakening the tibialis anterior and producing foot drop. The superficial perineal nerve is transferred to the peroneus longus, and the medial and lateral sural nerves are transferred to the gastroc motor points. The saphenous nerve can be treated in the thigh, in which case it can be transferred to the vastus medialis, or treated below the knee, being transferred to the soleus. The LFCN can be transferred to the sartorius or vastus lateralis. Given how common neuromas are, it becomes important to understand how and when they develop. Wolf-Tang et al. Retrospectively looked at 641 surgically treated neuromas via physical examination and chart review. Neuromas were either treated with excision and implantation into bone or muscle versus excision with direct nerve repair with or without nerve grafting. Rate of secondary surgery for neuromas was ultimately 7.8% and generally occurred at a mean of 16 months from the index amputation. Excision alone or excision with implantation into bone or muscle had a higher rate of secondary surgery compared to excision and direct nerve repair. It is important to note that patients presenting after above-knee amputation are most likely to have sciatic neuromas, whereas after below-knee amputation, the most common neuromas originate from superficial perineal nerve, saphenous, deep perineal, and sural nerves, with the tibial neuromas being relatively rare. So now we understand what Dr. Kasmers was addressing that day, a common perineal neuroma and the setting of prior below-knee amputation through delayed targeted muscle reinnervation. In the picture on the upper left, you can see the neuroma of the common perineal nerve. The picture on the bottom left is after TMR has been completed. This video, as long as I can get it to play, will show how the motor nerve is stimulated and its associated target muscle response. Now we'll move from neuroma management to an equally riveting topic, myoelectric prostheses. Types of prosthetics available include body-powered versus electric, as well as hybrids. Body-powered prosthetics use a system of cables and harnesses to convert movement at the shoulder into motion at the distal upper limb. Although these devices work well and are in wide use, they demand a certain level of physical strength from the patient and do not provide intuitive motion. Electric or power devices use motors to generate motion and mostly consist of myoelectric prostheses. As described earlier, these devices use EMG signals to control the distal limb. For the purposes of myoelectric control, targeted muscle reinnervation capitalizes on the fact that the peripheral nerve in an amputated extremity continues to carry neural information from the motor cortex. Therefore, a contraindication of TMR is a higher level complete nerve injury, such as a brachial plexus avulsion in the upper extremity upstream. Newly reinnervated target muscles provide new end effectors for this peripheral nerve information, amplifying it and interacting with a myoelectric prosthesis by means of surface electrodes. This allows a patient to volitionally and intuitively control their prosthetic, much in the same way as the original extremity. Pattern recognition of the EMG signals can allow for even greater prosthetic control. The image shown here reveals a myoelectric prosthesis socket with multiple surface electrode arrays for EMG signal detection and for the pattern recognition part of that. TMR for myoelectric prosthesis use involves the transfer of amputated nerve endings that formerly innervated distal upper extremity muscles to proximal motor nerve branches that innervate muscles with redundant function. As initially developed, TMR in the setting of transhumeral amputation was designed to create novel hand close and hand open signals while preserving native elbow flexion and extension signals. Elbow flexion and extension signals are maintained by preserving the musculocutaneous innervation of the long head of the biceps and the radial innervation of the long head of the triceps, respectively. The hand close signal is accomplished by transfer of the remnant median nerve to the motor nerve of the short head of the biceps brachii. The hand open signal results from transfer of the distal radial nerve to the motor nerve of the lateral head of the triceps. In patients with long residual limbs, transferring the remnant ulnar nerve to the brachialis muscle can create a fifth control signal that is often allocated to wrist control. The end result of this is 5 unique prosthetic functions. In the setting of new pattern recognition technology, even more unique functions can be produced by the terminal device. The best candidates for this procedure are young patients with cortical control of biceps and triceps contraction without plexopathy, supple tissue, and without cardiopulmonary risk factors. Bilateral amputations and long residual limbs also favor the procedure. Patients who have suffered avulsions of the limb at the time of the injury are poor candidates for the surgery. If the transhumeral amputation is long and the brachialis is preserved, the ulnar nerve can be transferred to the motor entry point of the musculocutaneous nerve into the brachialis. At the closure, an adipofascial flap is often placed back between the biceps heads to spatially separate the 2 bicep signals. Therapy usually begins 2 weeks after the nerve transfer procedure is completed. Taking this one step further, we'll consider the shoulder disarticulation level amputation. Surgical teams addressing this area need significant knowledge of the upper chest and axillary anatomy. TMR in this setting is even more challenging given the proximal extent of the nerve injury and the greater likelihood of damage to potential muscle targets. Additionally, skin envelope compromise often accompanies this level of injury. Preoperative assessment of both the remnant muscle function as well as the skin quality is critical. The first steps involving confirming the median, radial, and ulnar nerves elicit action potentials under cortical control, as well as the pectoralis, serratus, and latissimus muscles, as they represent potential targets for transfers. One must also confirm the presence or absence of a humeral head. If not present, the pectoralis major and other associated structures are 4 to 6 centimeters more medial than would be expected. Additionally, a humeral head indicates that there may be remnant triceps and radial nerve innervation present, which should be protected. Brachial plexus is painstakingly dissected out. The pattern of the nerve transfers in these patients is less dependent on accurate identification of the donor nerve and more subject to the spatial relationship between donor nerves and recipient muscle targets. In the end, each successful transfer will produce a myoelectric signal that can be used to govern prosthetic function, regardless of its location. Under ideal circumstances, the musculocutaneous nerve is paired with the motor branch of the clavicular head of the pec major. The median nerve and the ulnar nerve are transferred to the motor branches corresponding to split segments of the sternal head, and the radial nerve is coapted to the thoracal dorsal nerve, which is shown in that upper left photograph there. Kaiken et al. Published a case study in 2007 when all of this was starting to come out, focusing on one particular patient with a left shoulder disarticulation at the level of the humeral neck. The ulnar, median, and musculocutaneous, as well as distal radial nerves, were transferred to separate segments of her pectoral and serratus muscles. 2 sensory nerves were cut and anastomized to her ulnar and median nerve. The patient had the first indication of muscle reinnervation approximately 3 months after surgery. By 6 months out, she had strong signals that were recorded from all nerve transfer sites. She became proficient in the use of a prosthetic in a few days of training and was able to operate the hand, wrist, and elbow simultaneously. The shoulder component itself was a passive component. Examples like this make it easy to see why TMR has truly stunning potential when it's wielded in such a fashion. Salmanger et al. Recently published a standard nerve transfer scheme for both above elbow and shoulder disarticulation amputees. They note the fact that until TMR was developed, myoelectric arm prostheses were controlled by 2 surface electrodes that were themselves controlled by separately innervated muscle groups. Now, with TMR, it's possible to create up to 6 myosignals for intuitive and simultaneously control of different prosthetic joints. Above elbow amputees with a long stump and existing brachioradialis muscle can achieve 6 myosignals, while shoulder disarticulations can achieve a maximum of 5 myosignals. This allows for more efficient and harmonious control of a prosthetic device and eliminates the need for the change between different levels and joints. So now that we've reviewed the proposed benefits of TMR, it's time to discuss some of the controversy behind it. Almost 15 years after the advent of TMR, abandonment or non-use of prosthetic devices still represents a commonly faced problem and a big financial burden for the healthcare system. Prior to TMR, there was a documented abandonment rate of 50% for prosthetics. Salmanger et al. Evaluated this issue after the introduction of TMR, which in theory provided a more versatile and physiologic prosthetic. Despite finding improved functional outcome scores, they still found that 32% of patients did not finish prosthetic rehabilitation, stating that this is ultimately a failure of TMR. These patients identified that the weight of the device, the lack of feedback, and their inability to perform ADLs all contributed to this. Overall, the researchers identified lack of sensory feedback as a major obstacle to long-term prosthetic adoption. They did note, and I feel it to be relevant as well, that while prosthetic use may not be guaranteed, TMR still has a role in improving phantom and residual limb pain, and may be ultimately worth it in order to prevent patient pain and provide comfort and pain management strategies. It's also important to note that while TMR for myoelectric prosthesis use is becoming more common, it's by no means mainstream. As a result, therapists do not often interact with these patients. They're quite rare. Despite this, a regimented, lengthy protocol is required to facilitate patient use of a myoelectric prosthesis. Sturm et al. Published their 16-step therapy protocol just this year, emphasizing the fact that patients benefit the most when biofeedback training can be combined with therapist intervention, regular training with the prosthesis, and access to tabletop prosthesis training, as well as to the prosthetists themselves. It clearly takes significant investment on behalf of the patient, surgeon, and therapist to promote ultimate use of myoelectric prostheses. Another important issue at hand is the general cost of the procedure. When searching for reimbursement rates and for TMR, it's difficult to identify just how much money physicians and hospitals are charging for the procedure, which can include a number of CPT codes depending on the nature of it. When simply looking at the trend for nerve pedicle transfer from 2019 to 2020, one can see that the reimbursement has increased in the last year for that coding alone. Some institutions are more heavily involved in TMR procedures, and one could surmise that reasonable reimbursement rates for this procedure, as well as access to specialized surgeons who provide the service, could influence the decision to offer TMR in all settings. I have not personally seen TMR performed in our institution in the acute setting, but that would add a layer of complexity to every amputation, requiring surgeons to properly indicate patients that would benefit from immediate TMR. When I brought this up to Dr. Kasmers, his response was the following. If you see people performing TMR on vasculopaths with bilateral lower extremity amputation, who for sure will never ambulate again, you know the reason. He also kindly let me know that since he started performing this procedure approximately 6 months ago, he has discovered that the CPT code for pedicle nerve transfer does, in fact, pay extremely well. Beyond the topic of cost, I do think it's important to note that much of the research on TMR was started by and continues to be produced by a group of physicians and providers that have clearly dedicated themselves to this topic. While admirable in many ways, it also makes you consider the implicit biases that come along with research that supports a clinical agenda. I encourage any interested parties to check out Dr. Dumanian's internet presence, and particularly his dedicated web page, which espouses his research and provides insight into the mindset of this group at Northwestern. Finally, and perhaps most importantly, our outcome measurements for patient pain in the setting of neuromas are poor. Not only that, but there are many different outcome scores, none of which have been validated in this population, as well as confounding causative agents of pain in these patients, such as heterotopic ossification and abnormalities in bony anatomy. In many studies, patients struggle to differentiate residual limb from phantom limb pain, and there is, without a doubt, some component of coping and mental health that convolutes an accurate assessment of pain in these patients. Ancillary options to TMR exist, including RPNI or combination RPNI with TMR. We'll take a look at these options now. Regenerative peripheral nerve interfaces, or RPNIs, are created by wrapping transected nerve fascicular units with free muscle grafts. Kind of look like meatballs. These free muscle grafts are transferred and wrapped circumferentially around the amputated nerve stump and undergo a series of events, starting with initial immediate devascularization and denervation, then early graft atrophy and degeneration, followed by delayed revasc from the surrounding wound bed, and finally, neurotization of the new accepted graft. This produces specific reinnervated muscle units and allows regenerating axons from transected nerves to create new connections to those neuromuscular units. Valerio et al. Recently published a paper looking at 119 patients who had simultaneous acute TMR with pedicled vascularized RPNI performed at the same time in both upper and lower extremity amputation settings. They felt that the combination provided a vascularized, denervated muscle cuff that served as a buffer against axonal escape and possesses the potential for additional focal muscle target availability for reinnervation. RPNI is also thought to help address the mismatch between nerves during transfer when one is much smaller and the other is a lot bigger during coaptation. An even more recent combination on the scene includes TMR and osteo-integrated percutaneous implants. The first case of bilateral upper extremity TMR and OPIs was reported in November 2020 by Vincentorio et al. They performed combination TMR and staged OPI placement in a young female who lost bilateral upper extremities while working with agricultural machinery. And they determined that they had excellent outcomes in terms of her functional ability. The process took a significant amount of devoted time and effort on behalf of both the surgeon and the patient, and she underwent multiple staggered procedures to get her to this point. Now it's the time to step back from everything we've discussed and identify the most salient points that we can move forward with and the areas in which we can improve our use of this novel surgical treatment. There are several issues that I feel warrant discussion. TMR is an evolving topic that has been somewhat nebulous in its indications. At this point, it seems reasonable to make several suggestions. First, that TMR be considered for healthy patients that suffer traumatic limb amputations that have the soft tissue envelope and overall health to tolerate the addition of TMR to their index amputation. This does not include amputations performed for severe infections, vasculopathy, or in the setting of peripheral neuropathy. It is not clear whether it should be extended to patients who you will feel will never use prostheses unless you are concerned about preventing neuromas or managing pain. Next, it appears reasonable to continue secondary TMR in the setting of pre-existing neuromas, and possibly in the setting of residual limb or phantom limb pain, although this indication is somewhat softer. Secondary TMR is already performed at our facility with a collaboration between Dr. Saltzman and Dr. Kasmers. While TMR itself adds time to the surgery, as well as specialized fees for an additional surgeon and a fancy procedure, you can make the argument that it may also defer additional surgeries for recurrent neuroma pain in the future and possibly decrease pain medication usage in the long term, although research in this area is needed. At this point, there are no validated scores for recording patient-reported outcomes specifically for neuroma pain after amputation. Prior research has used a vast number of outcome measures which vary between studies and make comparison difficult. It seems reasonable to identify meaningful outcome scores at this juncture and use them to assess how we are impacting patients undergoing TMR. In theory, this could provide us with feedback about how effective and useful TMR is from the patient perspective, especially as we continue to use it and allow it to branch out to different parts of the body. Last but not least, here are the takeaways I hope that this talk provided. First of all, there is a role for TMR, despite its significant cost and relatively recent arrival on the scene. Second of all, there is reasonable evidence to suggest that TMR is most beneficial in the setting of preventing or treating neuromas. Even if the end goal is to support prosthetic use, it is certainly not a bad thing to alleviate or prevent nerve pain in the process. While the cost should always be a consideration, we should think about the money saved on future neuroma surgeries or long-term pain medication usage. This is ultimately a realm in which cost-effectiveness research may have an eventual role. Patients that undergo TMR with the end goal of myoelectric prosthesis use require an army of support outside the operating room, and this cannot be underappreciated. The attrition rate is high in the process. Finally, I'd personally like to move forward by identifying the appropriate patient-reported outcomes that show meaningful impact of the procedure. This is perhaps the most important point to me personally as someone who may perform these procedures in the future as an upper extremity and hand surgeon. Before I move on to my references, I have a quick additional poll for the group. I'll give you about 30 seconds to answer it. If anyone's still listening. Okay, a couple more seconds. So it looks like we have about 48% of people that would consider using it all the time. There's a group that still are not sure about it yet or do not feel like they have a good way to indicate patients. And about 20% no, do not feel prepared to use it right now. Seems about reasonable for where people are at overall. Here's a quick look at my references. And thanks for everyone's attention. I'm happy to take questions at this time.
Thanks, MJ. I'd like to open it up to people who are most knowledgeable at this. I think Nick, Kasmers, Hutch, some of the lower extremity folks, trauma surgeons, interested in your thoughts on this topic.
Yeah, MJ, great job. That was a nice overview of kind of a new, more recently popularized topic. So I appreciate your insights on that. Where do you think things stand with this? Clearly, like even in our own department, some people are into it, some are maybe skeptical, and some are in between. You know, we see this kind of curve with the any sort of new technology where you kind of have the early adopters and you have kind of people transitioning into like mainstream use of a certain, say, implant, and then after you get some results back, then sometimes we see a decline in use. Where do you think we are on that curve, and what do you think? It's hard to predict the future, but where do you think this is headed? Do you think this is kind of a fad, or do you think what you've read in terms of outcomes and literature seems promising enough that it might be something that sticks moving forward?
That's a great question. I think there are certainly institutions that have been in the forefront of this. Northwestern Memorial Hospital, Ortho Carolina, a few places have been doing a reasonable amount of this, and we're the early adopters. I certainly don't think that we are early adopters, but I don't think we're late adopters either. I think this is something where we've started to do this, like you mentioned, in the last 6 months or so, and I don't think it's going away. I do think it has a role. I think the myoelectric prosthesis part of this is incredibly fascinating, and for the right patient in the right setting with all the support systems in place, it can be an amazing thing. But I think the real silver lining here out of this research is the neuroma pain prevention and the control of neuromas in general. I think there's a lot of people suffering from that. There's a lot of amputations that are happening. And if this has a role in that, then I think it's not going away anytime soon. I do think our department will continue to do it, and hopefully more people will maybe see what you do and touch base with you if they have patients they think are appropriate, particularly young, healthy people with good soft tissue envelopes that, you know, were in terrible accidents and they want to get set up to have as few surgeries as possible. So I think having these dialogues between trauma departments, hand departments, people that are having, you know, amputees come through their doors just facilitates patient care and hopefully avoids additional surgeries and use of pain medications down the road.
Miranda, this is Kevin. Just a question. I know that they have been technically compared, but it seems the big question seems to me, what is the difference between truly sewing, you know, a cut nerve end to another nerve versus actually burying it in the muscle? Because I mean, as much as we say, well, in the past that was what we used to do, it's not really what we used to do. I mean, we used to sort of pull on these nerves and then cut them and they'd retract into wherever they were, which was hardly ever into a muscle. I mean, it was usually into, you know, the fat stripe that's around those nerves. And so I guess I'm a little skeptical that we really know what only doing that would accomplish in terms of the pain, not in terms of these myoelectric prostheses, but
yeah,
just in terms of preventing neuromas.
Yeah, that's a great question. I think there has been a number of papers that have looked at recurrence after traditional things, whether it's traction neurectomy or burying in bone or muscle. And, you know, the recurrence rate ranges there from, you know, low 40s to almost 50%. So it's relatively high. And so with these preliminary papers about neuroma prevention and with TMR, you're having resolution of in 80 to 90%, 90+% of people. And so that's encouraging to me. You know, I had 50% of patients coming back from neuromas with traditional methods versus a much lower percentage not experiencing that, I think. But I agree. I mean, the one RCT we had that was done by the people out of Northwestern only recruited that number of patients and certainly could have benefited from the 200 that they initially sought to recruit. I think the results are encouraging enough for me to at least consider this. And I talked to Dr. Kasmers a little bit about this and being like, what do you think are the hurdles for doing TMR? And part of it is, TMR takes some time, but in reality, if you're up to speed and you're doing this quickly, he can do one nerve in about 20 minutes. And so if you have a well-oiled machine, it wouldn't add too much OR time to getting that done and taken care of. And I would argue that would make sense, and if you can potentially avoid the risk of recurrent neuroma.
Miranda, go ahead. Sorry.
Hi, Miranda. This is Hutch. Hey, great topic for all of us, including, especially in my mind, the lower extremity. I think you've delineated how that can be beneficial. I look at our orthopedic department and I don't really know, frankly, about how often the foot surgeons see amputations after they've been going along for a while and having bad neuromas. I think my expectation is this is a rehab doctor's issue, and that's who's going to refer a patient to you for the secondary type problems more often. Now, I happen to know because I work with some of the rehab docs in research in this area, and they are aware of this and will refer, I think, bad neuromas to us to do this type of surgery, which I think you've delineated and people should realize is really probably state of the art for neuromas. Kevin, what you described is exactly what we've all been taught how to take care of an amputation. You cut the nerve back. What we're talking about as far as conventional surgery for a neuroma after the fact. In other words, after that's been done and they still have a bad neuroma, then you try to stick it into bone or stick it into muscle. That's what she's referring to. Now we're giving it something to do rather than just cover it up. We're giving it a purpose. And once it has a purpose of reinnervating a dead muscle, then it doesn't hurt, is the idea. Another interesting fact is that in my half-life of congenital hand surgery, I never care about nerves because they never form neuromas in kids because their brains are so good that they just take it away. So it's partly a brain plasticity issue as well. Final comment, Miranda, is that in the world of what you described as the world of TMR, where we're trying to, as far as prosthetics are concerned, we're trying to utilize the muscles and the nerves to help us via innervation of muscles and techniques that we've learned. The other entire large idea would be, and that's what we've done from a research standpoint at the University of Utah for the last 15 years, is to directly attack or attach things to the nerve to try to get direct impulses. And that can work as well. And the big failing of TMR for prosthetics, in my opinion, and many others, is the real issue for myoelectrics, besides getting it put into a muscle or into the bone with the way our group here at the VA are trying to do, which would help a lot with the feedback of that this is my arm, not this is a prosthesis sitting on my arm. That is beneficial. But the big key, in my opinion, is sensation. You don't have sensation in prosthetic, therefore it ends up in the closet. If we can give some sort of rudimentary sensation to the hand that is using and picking things up, and picking up an egg versus a flower versus a rock, it will give the patient, and it's been proven already by us and others, that it gives the patient a feeling that that plastic metal arm is actually theirs, and they embody it, and then they want it on because it feels like they're whole. That's the big key. And good luck trying to find good patient questionnaires to figure out if that's beneficial or not. But anyhow, excellent topic, and I just wanted to add those aspects.
Thank you.
Miranda, this is Rothberg. Just wanted to ask a question, maybe of you, maybe of the crowd. You know, we do a lot of amputations on the trauma service, and most of them in diabetics, not necessarily young people. But in the young people, I have probably done about 3 of these TMRs myself, and also been a part of a couple with plastic surgery. And the thing that is hard to wrap your head around is the fact that you're putting a nerve the size of a pencil into a fascicle that you need loops to see. And then trying to think that that's all going to connect up somehow appropriately. And I would say that of the TMRs that I've done, about half have worked, half have not. They've all been, not all, most of the 3, I think, have been in people with neuromas who've presented from the amputee clinic, and 1 was acute. I want to hear somebody tell me why that works, this incredible mismatch. And then my kind of comment to it is sort of cynical, that like, I think we're pushing something that reimburses very well, but doesn't have great long-term data yet.
Yeah, I think that's a great question, and some of the similar things I've talked to Dr. Kasmers about, and hopefully he can weigh in, because my response is probably not going to be as useful to you as his. But I think that there is a certain knowledge that comes into picking the motor target that you're attaching branches to, and I think that's partly why he uses that handheld stimulator, is to not only find a motor branch that is, you know, innervating a large amount of your target muscle, but a motor branch that's big enough to hopefully have a connection with the donor nerve that you're transferring. And the issue of the small and large coaptation is a real thing, and it's why they have mentioned using, you know, loops and magnification to do the epimesial to the epineurial sutures, with hoping to control the axons and kind of funnel them into that smaller recipient. But I agree, I think that is definitely something that there's an issue around, and that's kind of why RPNI has also been developed, kind of surrounding things in a little meatball of muscle, try to controlling the axons and sending them where they should be going. And you're right, that's certainly something that's been noted in the literature and is an issue that I picked up in my studies of this. In terms of the outcomes, yeah, I think we need to follow this. This is still new, and Dr. Kasmers and I have talked a lot about how are we going to look at his patients that he's done, and is there a way for us to kind of track outcomes in this? That's certainly the next step.
Yeah, MJ, I think that's a fair response to Dave's concern, valid concerns, Dave. I think, you know, we don't have the long-term data on this. It seems like the relatively short-term data, though. If you kind of compare the historical neuroma excision with a traction neurectomy versus this newer technique, it sounds like, at least comparing between different studies, the rate of recurrence is markedly lower. What we need is a big study where it's kind of one group of surgeons doing it, and rather than comparing to historical controls. Definitely we're lacking in, some basic science answer to your question. If we were to study this in animals or something, it might behave differently than in humans. I think the mismatch thing is interesting. I think it's kind of akin to putting a fire hose into like a little straw. Like, the straw will probably get some water in it if you turn the fire hose on. I think that's kind of as rudimentary as our explanation is at this point in time. How I interpreted Kevin's question, I don't know if this is what he meant, but I thought he was asking, is there a difference between coapting a big nerve into a small motor branch versus just putting the large motor branch or large nerve where you resected the neuroma into a patch of muscle? Again, I don't know if that's what he meant, but I'm not sure if it's really the nerve coaptation. I suspect you probably do have some forward progress of the axons through that, or if it's putting a bunch of axons right into muscle with denervated neuromuscular junctions, or both. That really is resulting in the effect. But the extremely low rate of recurrence after doing TMR is something that I think is interesting. But points well taken. I think on the flip side too, it reimburses well, but also for somebody who's like doing these surgeries on the non-nerve side, it also occupies the room for a while. So that's also a barrier, I think, in general.
Great. Any final thoughts, MJ, or anybody else in the crowd? Otherwise, I think that was a great discussion, and I'll be looking at this issue as the future goes on. I know many of us will.
Awesome. That's it for me. Thank you so much.
Okay. Thank you, everybody.